Discover the latest health tips, expert advice, and inspiring stories. This is the Health Channel Podcast. Your journey to better health starts now.
Hi. Oftentimes, we discuss a lot of illnesses and childhood diseases that can be prevented or maybe even curbsided easily. But some families are dealing with illnesses that are not preventable and that can't be prevented by a vaccine, such as chronic illnesses like asthma and allergies and even diabetes. Many parents are struggling not only with the initial diagnosis, but the continuous management of a child that has an illness or disease that doesn't last maybe just 3 or 4 days, but is actually part of their childhood. In the next episode of Ask the Doc, I'm going to answer your questions about chronic diseases in children, chronic illnesses that young children have to go through on the next episode of Ask the Doc. Welcome to Ask the Doc, a show where we encourage you viewers to send in your questions so that I can answer them in real time. I'm Dr. Scarlet Constant, founder of Constant Care Pediatrics. And I'd like to answer your questions that you might have, not only about the treatment, but also the management of some childhood illnesses. It looks like we have a question coming in right now. This question is from Kirsten. Hi, Dr. Constant. Both our families have a history of asthma and allergies. Now that my husband and I are expecting our first child, when should we start keeping an eye out for symptoms, and what would they be? That's a great question, Kirsten. And as you must know, having parents with a history of allergies, asthma, or even eczema, the triad, it gives your child a higher chance of developing one or even all of these illnesses. So when the baby is born, honestly, there's nothing to look out for in the initial newborn period. You're not going to really see any presentation. Eczema is very common in infancy, and it could happen to any baby regardless of a family history. But somewhere around 3 months, even up to a year, if and when your baby does develop any type of viral illness, such as a respiratory infection or a little cold, you want to look out to see if your child has a problem with wheezing or reactive airway disease. A baby that's going to have reactive airway disease as a reaction to some of the viruses is usually a baby that might be predisposed to asthma. This is not to say that a baby that wheezes will be an asthmatic in the future. These are just things to look for. This might be a child that may have asthma as a toddler. So a baby that wheezes, a baby that has uncontrollable eczema, a baby that you notice reacts a little more to foods and has a little more of a skin reaction to things than you're used to seeing is a child that could eventually have the triad. There are some other points to look for if you are concerned about your child later in life having asthma. Here are some of the signs and symptoms to look for. Number 1, shortness of breath. And this is with playing or laughter or just increased activity. If you notice your child has shortness of breath, then you might want to investigate a little further. Chest tightness or pain, it's very hard for a child to articulate those symptoms, but sometimes they might even say that their throat hurts. And really what they mean is they have some chest tightness. Of course, wheezing when exhaling, if you can hear a child wheezing without using a stethoscope, that is definitely a very serious sign. Number 4 is trouble sleeping caused by shortness of breath, coughing, or wheezing. So sometimes you can't tell that your child has shortness of breath, but definitely coughing in the middle of the night or waking up gasping or having a coughing fit is a troublesome sign. Number 5 is coughing or wheezing attacks that are worsened by a respiratory virus such as a cold or flu. So like I mentioned earlier, a child that has a mild cold or has the flu but ends up having respiratory distress associated with this is usually a child that might have asthma or might be predisposed to developing asthma. If you guys want to send in your questions, please send them in, and I'm happy to answer them during this segment. It looks like we have another question coming in. This question's from Betsy. Hi, Dr. Constant. We recently discovered that our toddler, who ironically is nicknamed Dusty, has allergies and a mild case of asthma. What steps can we as parents take to reduce triggers at home and when he begins attending school? Well, the first thing to do is if your child does have an allergy to dust, then I think it's really important that you minimize the dust in your home. And the way they have a lot of really great products out there now that will encase your pillows, encase your mattress in order to prevent a dust accumulation actually in your cushions or in your bed, because that's really where we find the most dust, believe it or not, is on the bed, on the pillow, on the drapes in your child's room, if there are drapes, carpets and rugs. These are all typical furniture or accessories that we have in our rooms that carry dust. So we really want to eliminate those things in case our beds and our mattresses and our pillows try to eliminate stuffed animals. I know that's very difficult, but if we can put stuffed animals elsewhere rather than on our bed, that can really help your child that has dust mite allergy. If there are specific allergies such as like dog dander or cat dander, of course you know how to avoid that. But dust mites I think is the hardest, especially when you're going on to school. Of course, in school you really can't control the environment, and that's when you really want to assess the level or how severe the allergy is in your child to see if maybe immunotherapy would be an option. Seasonal allergies are hard to prevent because, again, as the name indicates, it's seasonal. So if there's a high pollen count around a certain time of year in your city, then you really just would have to give antihistamines to your child in order to kind of dampen the histamine response, but you really can't prevent exposure. So in conclusion, the best thing to do is to try to prevent exposure of the allergens in your home if that is possible. Of course, outside of your home is a less controllable environment. But if your child's symptoms are not dampened by antihistamines or prevention at home, immunotherapy might be the right choice for you and your family. So that is something that you would want to discuss with your pediatric allergist. So it looks like we have another question coming in, and the question is from Mary Catherine. Dr. Constant, how does asthma affect a child's ability to participate in physical activities, and what accommodations can be made? Well, Mary Catherine, I always tell my patients that if their asthma is under control, there should be no limitations whatsoever on physical activity. It is still so important for our children to participate in physical activity, team sports. They need to play outside with their friends and not feel that they have some type of handicap or they're hindered in some way. So, of course, during an asthma exacerbation, which is commonly known as an asthma flare-up, we have to limit physical activity until the symptoms are under control. But an asthmatic who is well controlled and on their controller medication can absolutely continue their regular physical activities and be active. Now, that's not to say that some children might not need a bronchodilator before exercise or maybe right after practice. Maybe there are some cases where children with asthma have what's called exercise-induced asthma. And that is the symptoms of their asthma are only triggered with exercise or high activity. That is definitely a scenario. But in that case, the child will take their inhaler before practice or before whatever sport they're going to play or before PE. They would take the recommended amount of puffs from their inhaler, and then they can absolutely participate the way they want to. So there really shouldn't be any limitations on physical activity overall. And, it's important that they understand that. And as far as modifications at school, usually the only modifications that the schools like to know if the student is on medication. So you would want to communicate with your school, give them the medication or the inhaler with the appropriate doses as recommended by their pediatrician or a pediatric pulmonologist, and let them know that this is something that needs to be made aware by the PE coaches or whatever coach your child has so that they can intervene when needed. And after that, they shouldn't have any type of modification with actual activity. Okay, we have another question. Great. This is from Dylan. Greetings, Dr. Constant. I was one of those kids who grew up with allergies and asthma. I got weekly allergy shots and always carried around a bronchodilator, which sometimes left me feeling wired and shaky. Is this still the case with some of the pediatric allergy and asthma medications? Well, Dylan, to answer your question, unfortunately, yes, the allergy medications, excuse me, are definitely almost completely asymptomatic. The side effect profile is very minimal with antihistamines such as Claritin, Zyrtec, and Allegra, thankfully. So your children can take an antihistamine every morning before they go to school. If there are allergens that they're exposed to at school, they really should not suffer any side effects from that. Unfortunately, the same cannot be said with some of the asthma medications. The bronchodilators absolutely do cause tachycardia for at least 15 to 20 minutes, and that's because it is a bronchodilator, so it does act on the cells of the heart, and it does, as well as it smooths the muscle cells in the lung. So while it does help on the aspect of the lung, it does affect the heart by causing tachycardia. And some children feel it. Some children really don't notice this at all, but others do, and they not only feel how hard their heart is beating, but how fast it is beating, and it does give them that jittery sensation that they don't really like. Another medication is prednisone. Sometimes during an asthma exacerbation, we may have to prescribe, steroids to the child, and steroids also make some of the children feel a little jittery, maybe a little bit louder than usual. They feel almost like they want to jump out of their body, but it is a temporary feeling. It does go away, but this is absolutely a side effect of using the prednisone or using the bronchodilator. Okay, so please send in your questions, because I know as parents, it is very difficult to manage chronic illnesses like this, because it's not just a spurt of 3 or 4 days. You actually have to stay on top of your child, and in some cases even give medication on a daily basis, which I know that with children, this is very difficult. There are some days they don't want to take medication. Maybe they're tired of it. Sometimes you're very busy and you're out of town and you're rushing around and you're just not on your right schedule and doses get missed. So I know that this can be very difficult. And if you have questions or concerns, please send them to me so that I can help address them the best way that I can. It looks like we have a question coming in from Facebook right now from Cassandra. Hello, Dr. Constant. I had asthma as a child, which was problematic for a time, especially taking medication that would make me jittery. But I eventually outgrew it by my 20s. As a concerned parent, I'd like to know what causes it and what are some of the latest advancements in asthma management for children. Well, Cassandra, like I mentioned earlier, the bronchodilator works on the actual beta cells of your heart. So it does cause tachycardia, and it causes the heart to beat a little bit harder as well. And that is still a gold standard medication, a bronchodilator, because that allows the smooth muscle cells in the lungs to relax and open up and allow and kind of ameliorate the bronchospasm and allow more air to enter the lungs. So that's absolutely necessary. We are not using the bronchodilators, let's say, as frequently as we did before. There have been some new advancements where we found that with asthmatic patients that have a bronchospasm cough, that's kind of that very tight cough that they have, maybe without wheezing, that we can actually give an inhaled steroid rather than an inhaled bronchodilator, and that has been able to help with the bronchospasm. So in these instances, a couple of years ago, we were right away giving the bronchodilator, which causes the tachycardia, but now we found that a first line, we can use the inhaled steroid instead and see if we could keep symptoms at bay with the inhaled steroid. Also, years ago, we were using albuterol liquid to be given to the children to drink orally, and now that's no longer in use. It's just the inhaled, the meter dose inhaler or the nebulized solution. And also, we're not using oral steroids as frequently. Like I mentioned earlier, the prednisone is used for an exacerbation or maybe an asthma attack that is just not responding well to the inhaled steroid and the bronchodilator. Maybe then you have to go ahead and add the prednisone. So those are some advancements that have been made. It looks like we have another question coming in. This is from Javier. Saludos, Doctora Constant. I remember not being allowed to eat eggs as a kid, which truthfully I didn't mind. What are the most common food allergies in children, and how can parents prevent allergic reactions? Well, parents cannot really prevent allergic reactions aside from just abstaining from the foods that their child is allergic to. And you're not going to know what your child is allergic to until they're actually exposed to it. That is the reality. There are some common foods that we know are common allergens. For example, it looks like milk is the number one common allergen. eggs, peanuts, and, peanuts, we introduce peanut butter usually by 4 months of age, but it is still a very common allergen. Number 4 is tree nuts. 5 soy, 6 wheat, and 7 shellfish. And I know that initially we said to try to stay away from these common allergens in the first few months of life, but now we've kind of switched back, and allergists have encouraged us as pediatricians to really talk to families about introducing these foods by 4 months of age when you're introducing solids. As you know, we introduce solids between 4 and 6 months of age. So we are encouraging you to introduce eggs and peanuts and tree nuts. Now, with eggs, it's tricky. You want to introduce the yolk first before the actual white of the egg. And this reason being, the white of the egg is actually the most allergic part. That is usually, you're mostly commonly allergic to the egg white rather than the egg yolk. So we encourage you to introduce the yolk. And if your child is responding well to it, then we can give the whole egg. And then as far as tree nuts and things like that, we have to remember that those are also choking hazards. So the reason why we stay away from those in the young age is really just because you don't want to give your child a cashew to chew and swallow, because there is the risk of aspiration. But the other ones we like to introduce early. So just to reiterate what my colleague was discussing, it is absolutely a great idea to start introducing common allergic foods to your baby when we're introducing solids. Remember, if there is an allergic reaction, you should have Benadryl in the house to give your baby Benadryl if it's a skin reaction. If you think that there's an anaphylactic reaction, of course, you want to bring them to the ER right away. A little helpful hack is you can always touch your child's skin with the allergen just to see if there's a reaction. A baby that's going to have a significant allergic reaction to peanuts or peanut butter or eggs or soy usually will react just by the touch. So you can just rub it on their skin and see if they have hives or redness before you go ahead and introduce it orally. But remember, try to have some Benadryl at home just in case. Okay, looks like we have some more questions coming in. This question is from Nellie. Hello, Dr. Constant. My son Shiloh was recently diagnosed with type 2 diabetes. I'm a little embarrassed, always thought that diabetes was just diabetes. How does type 1 diabetes differ from type 2 diabetes, and what are the challenges in managing each? Well, that is a very, very loaded question. I'll try to answer it the best way I can and as simple as I can. There are 2 types of diabetes. Type 1 diabetes, which is also called autoimmune diabetes, is actually genetic. And that is the body actually is reacting to our pancreatic cells that release insulin. So the body's actually attacking those cells and destroying them so that the pancreas can no longer create insulin. So type 1 diabetes presents, or sometimes we've even called it juvenile diabetes, because it does present in the earlier years of life. And this is because this is actually genetically predisposed. The child is born this way. It just takes a while for all of the pancreatic cells to be completely destroyed and therefore no longer secreting any insulin whatsoever. So once the insulin levels are low enough, then the child starts to present all of the symptoms of diabetes leading to the diagnosis. Type 2 diabetes, on the other hand, is not autoimmune and it is not genetic. It is actually caused by an oversaturation, let's say, of the pancreatic cells and overuse of the insulin to the point where the pancreatic cells are no longer responding well to the signals that will cause them to release insulin. So let's just say they're overabused, and this is because this is an environmental illness. This is from, poor eating habits, poor exercise, and basically a glucose surge and overwhelming of the pancreatic cells that are no longer able to release insulin because they are not really responding to their signals. So 2 different methods, 2 different reasons, 2 different causes of diabetes altogether. And therefore, they're managed in a different way. Type 1 diabetes, you are actually getting insulin, exogenous insulin, because your body is not producing it itself. Whereas type 2 diabetes, we're actually taking medications in order to metabolize the sugar better and increase insulin levels in the body. So they are managed differently. A lot of diet modification, exercise modification in type 2 diabetes, and weight loss, of course, is another way to manage type type 2 diabetes. So there's a lot to do as far as management of the two of them. Type 1 diabetes is a lot closer management because this is now measuring blood sugars on a daily basis, and your child actually has to calculate the amount of sugar that they are going to ingest in order to know how much insulin to give themselves in order to metabolize this glucose. So it's very complicated between the two. I am sorry that your son has just been diagnosed with type 2 diabetes. I know that this can be very difficult, but please follow the guidance of your pediatrician and endocrinologist to help you give him the best possible and most healthy way of life with the type 2 diabetes. Okay, it looks like we have another question coming in. And this question's from Ian. Dr. Constant, my sister and nephew Bradley moved in with me a few months back, and I've noticed that Bradley seems to have to urinate rather frequently. Isn't that a telltale sign of diabetes? What are some other signs that parents should keep an eye out for? Well, Brett, that is one of the signs that perhaps your nephew has diabetes, or maybe is an early presentation of diabetes. But frequent urination is not the only thing. Excessive thirst, almost an insatiable amount of thirst. Doesn't matter how much they drink, they always feel parched. They always feel like they're not getting enough. And the frequent urination is so much so that a child that normally is potty trained or has been dry overnight starts wetting the bed more frequently, or even wetting themselves during the day. That's how much they have to go and how urgent it is. So you'll start to see enuresis, that we call it, or nocturnal enuresis, increased drinking of water in a way that just seems almost abnormal. You'll see weight loss, and you might even see that they are becoming a little more diaphoretic, meaning sweaty. But those are signs to look out for. But if you are concerned, please just have your nephew go to their pediatrician to have tests run on them. Okay, looks like we might have one more question coming in. Carlotta, Dr. Constant, our daughter Samantha has diabetes and is going to be going into first grade next year. How can parents help their diabetic child manage blood sugar levels, especially during school and extracurricular activities? Carlotta, there has been so much advancement in the management of type 1 diabetes in the pediatric population, thank goodness. But what we have is a continuous glucose monitor, which usually kids will either have in their backpack or on their cell phone. They have it with them at school, and it monitors their blood sugar throughout the day so that they don't have to constantly stick themselves. There are a lot of advancements, which of course you can speak to your endocrinologist about, to give your child more autonomy and help them monitor and be aware of their glucose status while they're at school, so that they can still participate and do everything with their peers. That's all we have for today. If you have any more questions, please call in or submit, and I'll try to address them on the next segment. Take care, everyone, and have a great day.
Thank you for listening to the Health Channel podcast. We hope this information has been useful. However, please remember that only your doctor can advise you about what is best for you. Do not start, modify, or suspend treatment based on anything you have heard on this podcast. Please join us again soon.